Hello, my name is Anne. I'm an MD and a PhD working as a junior consulting surgeon at Aarhus University Hospital in Denmark. I'm very happy to be invited to give this talk about the preservation of sexual function and rectal cancer treatment options. Preservation of functional outcomes, including sexual function, has recently gained more attention. And there is a risk of sexual dysfunction after treatment for rectal cancer. Surgery is the foundation of rectal cancer treatment, but with pelvic surgery, there's also a risk of direct nerve damage, even though the risk may seem low with a correctly performed TME procedure. However, surgery also causes scarring and fibrosis to the pelvic tissue. Some patients are also treated with radiotherapy, which is also known to cause sexual problems due to vascular and tissue damage and neurotoxicity. In Aarhus, we recently investigated a large national Danish cohort of patients diagnosed with colorectal cancer between 2001 and 2014. We compared rectal resection to patients with colonic resection and local or endoscopic excision. There were no significant differences in sexual function between patients after colon resection or local excision. But when compared to rectal cancer patients, rectal resection was highly associated to worse sexual function. In both male and female patients, the most significant treatment-related factors associated to sexual dysfunction were permanent stoma and the use of radiotherapy. The correlation between permanent stoma and sexual dysfunction may be due to the fact that most of the patients had an APRS procedure. But actually, we investigated the same association between colon resected patients, and we found that a stoma also in colon cancer patients have a negative impact on sexual function. A stoma may alter body image and sexual self-image, and these factors can deteriorate sexual function. And lastly, many patients after rectal cancer treatment, they also suffer from other side effects like bowel dysfunction and urinary dysfunction. We must remember that sexual dysfunction is not due to only physical side effects to treatment, but there is also a major psychological negative impact of the cancer diagnosis. Cancer is associated with stress, depression, and fear of recurrence, concerns that almost all patients or cancer patients share, things that potentially has a huge negative impact on sexual life. So despite a correctly performed TME procedure and no use of stoma or radiotherapy, some patients will probably still experience sexual problems. And in the individual patient, it's very difficult to quantify the role of each specific treatment component. And adding to this, sexuality and the perception of sexual quality of life is highly individual from one patient to another. So with today's treatment options, it seems unavoidable that some patients will develop sexual dysfunction. And we need to try to identify these patients, especially those planned for radiotherapy and permanent stoma. With screening, we will be able to diagnose more patients with early tumors accessible for local excision without the use of radiotherapy and permanent stoma. For some patients, sexuality may not be so important anymore, but all patients should be recognized and informed about it. And patients who consider sexuality as an important part of their quality of life, they should get offered professional counseling and early intervention during and after their treatment. Thank you.